Hi everyone, this is John Mandrola from the Heart.org Medscape Cardiology, and I'm here in Paris at the European Society of Cardiology Congress, and I'm pleased to have Nick Mills, who's at the University of Edinburgh, presented today the HiSTORIC trial as a hotline trial. And welcome, Nick.
Thank you.
Tell us about the top-line results of HiSTORIC.
So HiSTORIC was a step-wedge cluster randomized trial funded by the British Heart Foundation in the United Kingdom to evaluate the impact of introducing a rapid rule-out pathway with high-sensitive cardiac troponin. We randomized 7 hospitals across Scotland to implement the pathway and looked at 2 co-primary endpoints: effectiveness and safety.
Okay.
Does the use of a single high-sensitive troponin test and separate risk stratification and diagnostic thresholds to identify low-risk patients and allow them to be discharged directly, it improved the effectiveness of care? And critically, was it safe for patients? So the key results: the HiSTORIC trial reduced the length of stay in the emergency department by 3 hours across just over 31,000 patients in this trial. Furthermore, we increased the proportion of patients sent home directly from the emergency department by 57%, such that overall, in our trial population, 3/4 of all patients attending with suspected acute coronary syndrome were triaged directly to outpatient evaluation. Now, was it safe? So the primary safety outcome was a composite of myocardial infarction or cardiac death following discharge from hospital. And we evaluated that at 30 days and at 1 year. And we found that the event rates were 2.7% at 1 year in the standard care arm versus 1.8% in the early rule-out pathway, demonstrating that this acceleration of care and discharge approach was not associated with any risk to patients or adverse outcomes.
Excellent. I mean, this is great news. Tell us first about what kind of pathway this is exactly.
So it's designed to be simple, pragmatic, and easy for clinicians to follow. We have 2 separate thresholds, one to risk assess patients and one to rule in the diagnosis. If your troponin concentrations are below the risk stratification threshold, then you're triaged to the outpatient pathway. If you're above the 99th centile, sex-specific 99th centile, we recommend admission for serial testing at peak troponin concentration. If you're in the middle, then we recognize that small increasing concentrations within the reference range might be important, and those patients with rising concentrations within the reference range on a second test get admitted for further evaluation. As I say, 3/4 get evaluated to outpatient, 1/4 require hospital admission.
And tell us about what exactly is a randomized cluster randomized trial where you don't really randomize patients to.
That's correct. So there are a couple of key features of this trial. First of all, the enrollment and screening into the trial was performed by usual care doctors at the time that they order cardiac troponin. Secondly, we randomized hospitals rather than individual patients because we felt it was really important to evaluate the use of this pathway in all patients without selection bias. Thirdly, it meant that there was no researcher standing over the clinician with a Hawthorne effect, observing what they did and providing excellent adherence. This was something that was done by the doctors themselves. And finally, it was a data-enabled trial. So all of the insights, both the characterization of the patient population and outcome, were collected using routinely collected electronic data across these hospitals in Scotland.
So how did you come up with this pathway? I mean, I suspect it came from the previous high stakes trial.
So high stakes was our first step-wedge randomized trial. Here we evaluated the universal definition recommendations that we use sex-specific 99th centile diagnostic thresholds. And we learned a lot from the conduct of that trial. Principally what we learned is that high-sensitive troponin is a more valuable test at ruling out myocardial infarction and identifying low-risk patients than it is ruling in. In high stakes, we could not improve survival in those patients reclassified by the use of the high-sensitive assay. And I think we're still trying to understand how to get the optimal use out of the rule-in part of any pathway for acute chest pain.
Yeah, this seems to be, I want to move into, this seems to be a problem in the US. It's just sort of younger, less experienced with the troponin, high sensitivity troponins, and we're seeing more and more of these troponin leaks, so to speak, or we don't know what to do with it, and I'm concerned about maybe overdiagnosis and overtesting.
Yeah,
What's your comment on that?
So that was one of the key concerns we had, and that is why when we introduced the test into practice across Scotland, we did it as part of a stepwise cluster randomized trial, because the benefit of improved sensitivity is that you might improve the targeting of treatment to patients with coronary heart disease and improve outcome. But of course, reductions in diagnostic thresholds inevitably impact on specificity, and therefore it is plausible that you could see an increase in diagnosis, inappropriate investigation, and over-treatment that could cause harm. And so although the high-stakes trial did not improve our primary outcome in that trial of subsequent myocardial infarction or cardiac death, we did not find evidence of harm or over-treatment. No excess bleeding, no misdiagnosis and alternative death. So the adoption of high-sensitive troponin, although it generates anxiety sometimes when you make a change, it did not have any detrimental effect on patient care. So I don't believe it is leading to overdiagnosis. I think clinicians are having to think more carefully about the interpretation of the test, but I think that's a good thing. And I think what HiSTORIC tells us is that we need to move away from this being some sort of binary test for a heart attack. The troponin is positive. Call the cardiologist. You know, this is a continuous marker of injury to the heart that informs on a wide range of diagnoses and ultimately is a very powerful test of cardiac outcome. The challenge for a cardiologist and the ER physician is to understand what pathway that patient needs to go into. And a lot of patients with heart failure and other comorbidities have myocardial injury. That is real, and it's because their heart is not healthy, but they don't need the cath lab.
I want to push you on, I heard you say 75% of HiSTORIC were discharged with a single troponin and no inpatient testing. Now, did they get outpatient testing, or do you have that data? Or?
Yeah, that's a great question. So just to clarify, 75% overall were discharged, remembering there's an intermediate risk group who have 2 tests. So although the majority went home with a single test, some did have 2 tests in the emergency department. And one other clarification I think is really important is in the high stakes pathway, which we use in the HiSTORIC trial, we always recommend 2 tests in early presenters. So patients who come in within an hour or 2 of the onset of their symptoms, really important to do 2 tests. So not everyone has a single test.
Okay.
On to your question, though, about downstream investigation, this varies all across the world. In the US, everyone gets a stress test, a nuclear test, and a number of other tests.
Tell me about it.
Probably a CT thrown in now. In New Zealand, in Australia, they treadmill everybody. The evidence base for any of these approaches is completely lacking. We have no randomized trial of any particular investigative strategy. In fact, our next trial, little plug, Target CTCA, is a randomized trial of the intermediate risk group identified between these thresholds to try and provide some evidence-based guidance on what investigations are indicated in this setting. But I think those that are below the risk stratification threshold, less than 5, we know from our article published in Circulation today online that their event rate at 1 year is 0.5%.
Which is the same as the standard
general population.
Yeah.
General population. So I think, you know, if in terms of concentrating our efforts to investigate patients by using separate risk stratification diagnostic thresholds, I think we will become better at targeting these very valuable investigations to the right patients. And again, to directly answer your question, do I have the data as to what downstream tests were done in our trial population? Not yet.
Okay. You also mentioned sex-specific thresholds.
Yes.
Speak on that.
Yeah, so this has been an area of, I would say, some controversy over the last couple of years. I don't think it's controversial at all. There was a systematic review done of over 30 different reference range studies done in populations across the world for every troponin assay available. And consistently, the upper limit of normal in women is substantially lower than it is in men for all tests. And so if we are going to follow the universal definition's recommendation that we use the upper reference limit of normal to diagnose myocardial infarction, we must take into account that there are differences by sex. I think it's fairly clear.
But also more complicated.
I have to say, having implemented it in 10 hospitals in Scotland, it was not complicated in the slightest.
Okay.
within 2 days, people got it. We have different reference ranges for hemoglobin for men and women. I don't think that causes too many challenges in day-to-day clinical practice. It's easy to incorporate it into your reporting system in any electronic patient record system.
Now, another question that comes up with high sensitivity troponin that never came up with older troponins is the use of it as a potential risk marker or biomarker.
Yes.
Do you have any feelings about that?
Yeah, I think what we're learning actually is one of the reasons why it's so powerful at identifying low-risk patients in the emergency department is because actually what it is a barometer of heart health. It's got very little to do with the diagnosis of heart attacks at that level. It's telling us how healthy your heart is and whether you've got active coronary disease, underlying structural heart disease, or comorbidities that might influence your heart health. So it's a very powerful tool. It reflects a range of pathologies, which is our challenge. But in terms of how we might use it in the future more broadly with the emergency department, I think there are a range of different applications. There's a lot of interest in using it as a primary prevention or a screening tool. I think we need more evidence that actually reporting that result to an individual would in some way impact on the way that they consider their risk and have some relevance to the clinician managing their care. What would they do differently as a consequence of this information? So I think there's a lot of enthusiasm. I think there's a great opportunity here, but I think the research community need to design the right trials to demonstrate the value of this test more broadly. I think we're really learning how to use it in the acute setting, but we've got some way to go to try and understand how to use it in the chronic disease setting.
Yes, I love that word of caution. So on that note of caution,
Yeah.
I'll say thank you for joining us. It was great talking to you.
Pleasure.
Okay.